Diabetic foot infection. So whenever you have a patient with diabetic foot infection, your antibiotic coverage will be polymicrobial. So you have to cover gram-positive MRSA, you have to cover gram-negative Pseudomonas, you have to cover anaerobes, and you have to cover, these are the organisms you have to cover. So you can cover with so many different options. So gram-positive, so MRSA can be covered by vancomycin. Gram-negative, you can do it with zosyn, which will cover both anaerobe and Pseudomonas 2. The other choice is, or you can do vancomycin. If you are worried about vancomycin zosyn combination, which can cause AKI, you can use cefepime for Pseudomonas coverage. And for anaerobic coverage, you can add flagyl. So this is how you treat the patient. So in diabetic foot infection, if they are septic, you will get the blood culture, you'll get the wound culture. You can involve wound care specialized nurses. You have to control sugar. You have to start this patient on IV fluid, and then definitely antibiotic. If the diabetic foot infection is bad and you are thinking that the bone might be involved because from the diabetic foot infection, then you have to do more imaging. You can consider MRI. You can start with X-ray of the foot, and if it is showing necrotic bone and you are worried about osteomyelitis, then get MRI. And if it is MRI showing osteomyelitis, then you have to involve surgery for possible amputation. So let's look at it quickly. Risk factors we already know: uncontrolled diabetes, they have a neuropathy, previous history of amputation, uncontrolled diabetes, CKD, peripheral vascular disease. Okay, that's another thing you can order too. So if you are thinking diabetic foot infection is because of peripheral vascular disease, you can order arterial Doppler of lower extremities. Pathogen involved, like I said, is polymicrobial. It's polymicrobial infection. And if you are suspecting gangrene, gas gangrene, then involve Clostridium too. Otherwise, it's polymicrobial. So they will have ulcer, it has redness, swelling, tenderness on palpation. It might have purulent discharge. If you do the probe test, which is you will put a small stick and try to put it in the ulcer, and if you can feel the bone, that is called probe test, and that is positive, then patient most likely have osteomyelitis too. You can order all the tests. We already discussed about that. Check the inflammatory markers: procalcitonin, lactic acid, wound culture, blood culture, bone biopsy if the bone is involved, MRI if needed. You can assess the severity of foot infection: mild, moderate, severe. So greater than 2 inflammatory marker like pain, redness, swelling. And if cellulitis is less than 2 centimeters around the ulcer and infection is limited to skin and superficial, then it's mild. If it involves more than 2 centimeters with abscess, gangrene, involvement of muscle, systemic symptoms, is moderate. And if the patient is septic with organ involvement, severe. Treatment we already discussed. We discussed about antibiotic. You have to do tight glycemic control, electrolyte replacement, antibiotic, wound consult, surgical consult, depending on the clinical severity. So we discussed about antibiotics. So here they are discussing about antibiotics specifically. If it is MSSA, so initially when the patient is admitted, you have to start broad. You have to cover polymicrobial. So vancomycin, you have to cover Pseudomonas coverage, maybe zosyn, anaerobic coverage, and you order the culture, wound culture, blood culture, and based on culture result, you might have a specific pathogen and you can change your antibiotic according to that. And we already discussed all the antibiotics: MSSA, cephalosporin, Strep plus MRSA, you can use combination of strep plus MRSA coverage. MRSA, we discussed the antibiotic. Gram-negative organism, third and fourth generation cephalosporin, carbapenem, quinolone. Anaerobic organism, flagell, Clinda, unisin, zoosin. So we discussed about antibiotic.